Good morning, and thank you for the invitation to speak this morning. I'm going to spend the first 10 minutes speaking on functional mitral regurgitation and then the following 10 minutes on functional tricuspid regurgitation. It's quite a big topic to speak in 10 minutes, so I'll just be giving the key points, summarizing how the annulus, the leaflets, the papillary muscles, and the ventricles are affected in functional mitral and tricuspid regurgitation. And I'm going to share some insights we have gained from cardiovascular magnetic resonance on this subject. It is an ideal tool to image the heart because it is able to give very detailed information on the geometry and also the function of the mitral valve apparatus, and along with areas of infarction with late gadolinium enhancement. But first of all, some definition. So, functional mitral regurgitation is mitral regurgitation resulting from geometrical distortion of the subvalvular apparatus, secondary to LV enlargement and remodeling due to idiopathic cardiomyopathy or coronary artery disease, so-called ischemic mitral regurgitation. I'll focus more on ischemic mitral regurgitation because that's the more established intervention on the mitral valve when we talk about mitral repair for functional mitral regurgitation. So functional ischemic mitral regurgitation occurs secondary to ischemic heart disease or myocardial infarction. This results in left ventricular dysfunction and dilatation, which may be regional or global, which in turn causes papillary muscle displacement apically and laterally. And this results in a mitral leaflet tethering lesion, usually in the posterior medial P3 scallop, with or without annular dilatation. And the resulting dysfunction is that of a Carpentier type 3B dysfunction with leaflet motion restriction during systole. It occurs in up to 40% of patients following myocardial infarction, but it is usually mild or moderate in severity, and so it is often ignored. And even if it is diagnosed, it is often not treated. But it is not a benign condition because the incidence of heart failure and death is increased by up to 5 times with this condition. And even with successful coronary artery revascularization, whether by PCI or CABG, the risk of heart failure and death is 1.5 times above normal. This is a study on the normal motion of the mitral annulus and leaflets using cardiac magnetic resonance. And here on the horizontal axis is the timeline, and on the vertical is the septal lateral diameter of the mitral annulus, or the anterior-posterior diameter. And we can see that there are 6 distinct phases of the cardiac cycle which can be identified in relation to annular motion and leaflet motion. And there's a pre-systolic contraction of the mitral annulus, as you can see here, and the mitral annulus then relaxes throughout systole so that it is largest just at the onset of diastole when leaflets open. And also there are 6 distinct phases of leaflet motion, which is closely related to mitral annular motion. Now, this pre-systolic contraction of the mitral annulus appears to be impaired in patients with ischemic mitral regurgitation, as you can see here in this column. The blue charts represent early systole and the red late systole, and there's virtually no difference in the diameters in patients with functional mitral regurgitation, compared to patients without functional mitral regurgitation, in which you can see a distinct change in the diameters. And this is important to appreciate because it underlines the importance of undersizing the annuloplasty ring, even if the mitral annulus does not appear very dilated when inspected surgically, because we are in effect fixing the mitral annulus in systole and correcting for this loss of contractile function of the mitral annulus. Of course, with progressive mitral regurgitation, ischemic mitral regurgitation, the mitral annulus itself also dilates. And this is another study also using cardiac magnetic resonance. in patients with severe ischemic mitral regurgitation. And you can see here, this diagram is an inverse of this image. So this is the anterior annulus, that's the posterior annulus. And you can see that compared to patients with no ischemic mitral regurgitation, there's significant dilatation, not only of the posterior annulus, but also of the anterior annulus. Along with that, there's a flattening of this saddle shape of the mitral annulus. And the dilatation is most marked in the anterior-posterior direction, points 1 and 0.5 velocity, and also in the around the posterior commissure, 0.6. The saddle shape of the mitral annulus is accentuated during the cardiac cycle and is accentuated most during systole, towards the end of systole in a normal patient. And this change in the geometry of the mitral annulus is lost in functional mitral regurgitation. And these authors, Gorman et al., have demonstrated that this loss of the change in the saddle shape during the cardiac cycle results in an increased stress in ischemic on the mitral leaflets. And so there may be implications in terms of the geometry of the annuloplasty ring to optimize the repair. Moving on to the mitral leaflets, we know that leaflet tethering and restriction occurs, and this study just confirms the significant tethering of the mitral leaflets in ischemic MR compared to those with no ischemic MR. But along with that, the motion of the leaflet is reduced as well in ischemic mitral regurgitation, and there's reduced separation of the mitral leaflets during diastole. And this is almost certainly related to the reduced annular function in ischemic mitral regurgitation. More recently, this group from Massachusetts, Chaput and Levine, have demonstrated that the mitral leaflets actually adapts to ischemic mitral regurgitation by enlarging. In an attempt to decrease the regurgitation, the leaflets actually enlarge. And they were able to measure the total surface area of the mitral leaflets, including the coaptation zones. And they demonstrated in this white diagram that there are three groups of patients. The first were normal patients without any mitral regurgitation and without LV dysfunction. The second group were patients with functional mitral regurgitation, secondary to inferior wall motion abnormalities or dilated cardiomyopathy. And the third group were those with dilated cardiomyopathy or inferior wall motion abnormalities, but no functional mitral regurgitation. They demonstrated that those with, in these two groups with LV dysfunction had an increased leaflet area and an increased annular area compared to normal. So the annulus dilates, and along with that, the leaflets also enlarge. In their model, they were able to work out, based on the altered geometry of the mitral annulus, taking into account annular dilatation and also leaflet tethering, what the area of the leaflets had to be to achieve leaflet coaptation and valve competency. And they can see here that in those who had functional mitral regurgitation, a larger surface area of the leaflets was required. And what they demonstrated was that when you take the ratio of the leaflets to the annulus, this was constant in all three groups. So the leaflets enlarged with the annulus. But in the group with functional mitral regurgitation, the ratio of the leaflet area to the area required to achieve valve competency was significantly reduced in those with functional mitral regurgitation. So what they are suggesting is that in these patients, the mitral valve leaflets had failed to enlarge sufficiently to overcome the mitral regurgitation. So is it time to update the definition of functional mitral regurgitation to include structural changes in the mitral leaflets with left ventricular dysfunction, as suggested in this editorial in Circulation? If this is the case, then there may be newer strategies to mitigate functional mitral regurgitation by promoting leaflet adaptation, leaflet enlargement at the cellular level, and also novel surgical treatments to treat this, such as leaflet augmentation. papillary muscles are displaced, as we mentioned, in ischemic MR, but what direction are they displaced in? They are certainly displaced away from each other, as you can see in this group with functional MR compared to those, in this group with functional MR compared to those with no functional MR, a significant displacement away from each other. They are displaced posteriorly and laterally, you can see significantly, but not apically. And it does suggest that in terms of the newer adjunctive techniques which have been proposed at the subvalvular level, strategies to locate the papillary muscles towards each other may be more effective than strategies which attempt to approximate the papillary muscles towards the mitral annulus, because the annular displacement is more in the posterior and lateral direction rather than in the apical direction. Papillary muscle dysfunction does occur in functional ischemic mitral regurgitation. You can see here in normal patients, the papillary muscles contract by 30 to 40% during systole, and this is significantly reduced in functional ischemic mitral regurgitation to about 15%. In selected patients, it may cause valve prolapse if the adjoining wall of the left ventricle to which the papillary muscles attach have not had time to remodel and dilate. But this is very unusual because most commonly, if the papillary muscle is dysfunctional, there is also infarction at the area of insertion of the papillary muscles to the left ventricle. And this area remodels and dilates. And so papillary muscle dysfunction with elongation or lack of contraction during systole may actually decrease ischemic mitral regurgitation because it may decrease the leaflet tethering in this condition. Papillary muscle infarction does occur as well, and this is data from cardiac magnetic resonance in 10% of anterior lateral papillary muscle and 35% of posterior medial papillary muscle. And this is related to the different blood supplies of the posterior medial papillary muscle compared to the anterior lateral papillary muscle. But papillary muscle rupture is very rare nowadays because of the early revascularization with infarction. Myocardial infarction can occur throughout the ventricle, but is most common in the inferior lateral wall in segments, LV segments 4, 5, 10, and 11, as shown in this diagram. So we can think of ischemic MR as a balance of forces between forces which tethers the mitral valve leaflets and forces which close the mitral valve leaflets. So we have forces which causes leaflet tethering, such as annular dilatation, impaired function, annular flattening, papillary muscle displacement, LV dilatation. But on top of that, the forces which try to close the mitral valve are decreased because the LV function is impaired. There may be some LV dysynchrony. And coupled with that, there may be inadequate leaflet enlargement. Moving on to functional tricuspid regurgitation. Functional tricuspid regurgitation is, of course, tricuspid regurgitation without organic valvular or myocardial lesions, as defined by Professor Carpentier in his textbook. The most common cause of this is secondary to mitral regurgitation, and which causes tricuspid annular dilatation, RV dilatation, and dysfunction. It is by far the most common cause of tricuspid valve dysfunction, occurring in less than 1% of the general population, but more commonly in patients with heart failure, in up to 35% of patients. An important point to appreciate is that the severity of tricuspid regurgitation is variable in a given patient and is dependent on the preload, afterload, and contractility. And this is because of the very compliant nature of the right ventricle compared to the left ventricle. The tricuspid annulus, when it dilates predominantly in the anterior segment and the posterior segment. In this study by Deloche, it dilates more in the posterior segment than the anterior segment. Dilates a bit as well in the septal annulus, but less so. If we were to systematically examine every patient coming for mitral valve surgery, up to half of these patients are reported to have tricuspid annular dilatation, as shown in this study, a dilatation above 70 millimeters. An annular diameter of above 70 millimeters measured intraoperatively from the annular septal commissure to the anterior posterior commissure corresponds to a diameter of 40 millimeters measured by echocardiography in the four-chamber view. Because by echocardiography, what is essentially being measured is the distance between the middle of the septal annulus to the middle of the anterior annulus, as shown in this diagram. And we can see from this study here that as the tricuspid annulus dilates above a diameter of 40 millimeters, the severity of tricuspid regurgitation increases. But a tricuspid annular diameter of 70 millimeters, which is twice that above normal, is really quite a dilated tricuspid annulus. And this study on porcine hearts shows that tricuspid regurgitation rarely starts to occur when the tricuspid annulus is dilated to 1.4 times above normal. And so it does suggest that perhaps 70 millimeters is too high a threshold for an indication of tricuspid annuloplasty, and that it may be necessary to decrease the threshold a bit. The tricuspid annulus is, of course, a saddle shape as well, just like the mitral annulus. And the newer tricuspid rings do resemble the shape. Just as in functional mitral regurgitation, the saddle shape is lost in functional tricuspid regurgitation, as this study demonstrates. The y-axis is the height of the tricuspid annulus at various points above the annular plane. And you can see that with increasing severity of TR, the annulus becomes a virtually flat structure. Leaflet tethering contributes to tricuspid regurgitation, as demonstrated in this study. With increasing tethering area, the volume of tricuspid regurgitation increases, and this may be an important pathology to address in functional tricuspid regurgitation. And papillary muscle displacement occurs. You can see it here in this porcine heart study that annular dilatation alone results in malcoaptation of the tricuspid leaflets. Papillary muscle displacement alone also causes impaired coaptation of the tricuspid leaflets, and when the two are combined together, the area of malcoaptation is significantly increased, and it may be important to address both rather than one if both are present. But the direction of LV this enlargement or change seems to be important in tricuspid regurgitation, and this study demonstrates that the RV eccentricity index is an important determinant of tricuspid regurgitation. RV eccentricity being the ratio of this dimension C divided by dimension D, as measured in a short axis view on echocardiography. And this group then look at the various parameters which are responsible for functional TR, and this ROC curve shows that the right ventricular eccentricity index was actually the most important determinant, with an area under the curve of 0.9 when the eccentricity index was above 2. And when the tethering area was above 1 centimeter squared, the area under the curve was 0.75. When the end-diastolic tricuspid annular diameter was above 3.9 centimeter, the area under the curve was 0.65. So we can think of functional tricuspid regurgitation as essentially comprising 3 stages. In the first stage, there's mild tricuspid annular dilatation. Tricuspid regurgitation may or may not be present, depending on preload, afterload, and RV contractility. In the second stage, with significant tricuspid annular dilatation, tricuspid regurgitation will occur. And in the third stage, when there is, in addition to tricuspid annular dilatation, tricuspid leaflet tethering, tricuspid regurgitation is almost always present and significant. So I'd like to conclude by saying that understanding the pathophysiology of functional MR and TR is key to the assessment of this condition and to successful treatment of this condition. The evaluation and treatment of all the underlying pathophysiologic etiologies, lesions, and dysfunction is necessary. Annular dilatation, impairment and flattening, papillary muscle displacement, leaflet tethering, inadequate leaflet adaptation, LV dilatation and dysfunction, RV dilatation and dysfunction, and of course, correction of the underlying etiology, ischemic heart disease if present, atrial fibrillation if present. Thank you very much, and thank you to the association again for the invitation to present this morning. Thank you.